Hello, my name is Ara Keshishin, and I'll be talking about obesity, medical and surgical treatment options, and their relative outcomes. First, I would like to thank the Armenian American Medical Society's CME and the Board of Directors for asking me to present. I've been asked to there is no financial disclosures to be made, and I would like to essentially start the presentation by going over some basic understanding of what we know about obesity, the diagnostic criteria, and then discuss about the historical perspective and how we've arrived today to the surgical and medical options that are available. It is important to appreciate that obesity cannot be just simplified into a disease of overeating, a lack of exercise. There is a significant amount of information that has come up in the last 10 to 20 years that points out to the multifactorial and multimodality aspect of the obesity. Interestingly enough, we'll talk later on about the GLP-1 type of medications, Wegovy and Ozempic, and that's an example of how numerous multiple pathways that control metabolic and energy balances play a role into obesity, and which explains and supports the idea of why patients can't just lose the weight by either decreasing their energy intake and joining a gym, for example. Looking at these multiple variables, it is important to appreciate that not all patients will have every aspect of them, and there are patients that primarily have hormonal disturbances, practices that primarily, for example, deal with infertility. Very frequently we'll have patients that have some element of thyroid dysfunction, and even though anatomically and physiologically they may have all of the proper level and functioning of the sex organs and anatomy, they still can't conceive. So that may be an example of how minimal hormonal disturbances can have significant long-term consequences physiologically. When it comes to psychological components, for the longest time there had been an incorrect connection between obesity and depression, where patients were told or led to believe that the connection between depression and obesity was a cycle where a patient would get depressed and that would lead them to make poor choices, and as they would gain weight they become more depressed. It wasn't until the recognition that the SSRI medications versus tricyclic antidepressants, even though they were treating the diagnosis of the depression, were functioning differently. So the recognition was that the connection between depression and obesity is not necessarily a cause and effect type of a thing, but both of them have to do with the serotonin uptake, generation, and metabolic derangement, which is why you see different weight loss profile in the treatment of depressed patients when they're treated with SSRI versus tricyclic antidepressant. Extension of this may be a patient's exercise tolerance. I mentioned the thyroid dysfunction earlier. It is not also uncommon where we may see patients in our office that have all of the diagnostic criteria of a hypothyroidism, depression, infertility, hair loss, heat or cold intolerances, fatigue, and yet when their TSH levels are checked as a part of a thyroid panel, the patients may be dismissed as not a thyroid related problem. It is quite frequently we see those patients where we start them with a low dose thyroid medication in lieu of having a theoretically a normal thyroid functional labs, and with a very low level thyroid medication they improve. A subset of patients, this group patients also may have some level of adrenal insufficiency, where low dose steroids transiently also help them to improve the response of the thyroid that they either have intrinsically or they get in a form of a prescription, and they significantly improve symptoms and their weight. When it comes to obesity, in a general terms, in the last 30 years or so, this graph from 2023 shows the increasing incidence of obesity in both male, female, and general population. There's been parallel between both sexes, and we continue to see this not only in developed countries but also in developing countries too. From a global perspective, there are dire consequences of the continuous rate of obesity, not only from comorbidities but also from health expenditure, cost of the treatment of the patients, both again from an obesity perspective and from the comorbidities perspective. Want to shift gear and then think about the treatment options that are available. When we're looking at the treatment options, we look at these into two different forms of treatment, and this is after the patient has already made a decision by themselves, having tried multitude of dietary plans and exercise plans, be just going on diets that they may get from social media or getting Weight Watchers and the like. And going to the gym with a trainer. The ideal treatment when we're looking at this, before we start thinking about what should or should not be recommended to our patients, we need to look at the big picture of each one of the treatments available. The medical or the surgical treatments need to be effective. This means that we need to really read the fine print. We will highlight some of those fine prints that are not at all transparent to the clinicians or the patients, and we have patients in our office that are requesting treatment A or B based on what they saw on a TikTok or a Instagram posting, or they saw a news clip at 8 o'clock on a local channel, for example. So the effectiveness of a treatment needs to be understood. The weight loss needs to be durable. There may be a lot of treatments that may have relatively good short-term result over a matter of days, weeks, or months, but then over time they resolve, and the weight loss goes away. Patients gain their weight back, and then comorbidities return. Next item would be the treatment needs to be reproducible. Quite frequently, we may see publications or data that's very specific to a subset of patients. A group of medications may work well for, or a treatment plan may work well for a patient of a certain age, ethnicity, and it may not be applicable to the population at large. As far as treatments, the next item would be ideally we want to have the lowest side effect and risk with the most benefit. We all in clinical world appreciate that everything that we do, whether it's writing a prescription, recommend a certain treatment plan, or offer the patient surgery, each one of these treatment modalities have certain risks associated with them. The key would be for us to be able to identify the relative risk versus the benefits that the patients get. Very frequently, the lowest risk treatment option is not the best for the patient, because as low as the risk may be in relation to the effect that it delivers, it is still a very high risk since the benefits are nil or negligible. So I think it's important that we avoid walking down the path of focusing only, well, a procedure, since it has the lowest risk, it must be best. And we will talk about this a little later on a few slides. Last but not least is the issue of the affordability, which we always think about it in the terms of patients have insurance, but as more and more patients have elected to seek treatment and payments outside their health plans payments, such as Ozempic or Wagovy, now we're experiencing and seeing patients where they're coming to our office where somehow they got a prescription for another clinician to get this medication at a tune of hundreds of dollars a week. Their employment environment has changed, their financial situation has changed, they had to cut the medication off, and now they're experiencing weight gain and they want to know what they need to do. So I would bundle that the issue of the affordability needs to be included also in the evaluation of the long-term risk of being able to afford the procedure or the treatment for the best benefit. When we're looking also at the treatment options, we need to avoid anecdotal information. As bariatric surgeons, most if not all of the surgeons and those of us that are in clinical practice follow the MBSA QIP standards, the American College of Surgeons Center of Excellence certification process. There are also significant large body randomized trials and studies by Swedish object subject, the SOS studies, and the National Institute of Health Diet, Kidney, and Diabetes Institute publications. The idea of following the disciplined structure and published data is to be able to quantify not only the outcome but also the mortality when we're discussing this information with the patients, for example. I'm going to dive in right now to the first phase of first line of these modality of the treatment, which would be the diet plans. It should be to no surprise to anyone who's attending that most of the diets fail, and they also fail because they also fail most of the criteria that we outlined earlier. They may not be effective. If you look at the published data for most of the diets out there, they have low durability and low effectiveness. They work for a certain group of patients and they only work for a short period of time. They also, interestingly, are not reproducible population-wide. It's interesting where you look at the published data, certain ethnicities do better with certain types of diet versus other ethnicities. Affordability becomes an issue long-term, where if you have to subscribe to a certain diet formula, supplements, and they may have relatively low risk, but the collective ratio of risk to the benefit is also very low. They all have meager yields, limited weight loss, and low durability. When we look at the medications, and this does not include the GLP-1, which is what we will talk about here at length shortly, is the drug therapy has historically been unsuccessful to producing sustained weight loss. We all remember the fen-phens, where they worked sort of the class of amphetamines, essentially, where they worked well and the patients ended up with significant cardiac issues and hypertension. It is also surprising where still phentermine is prescribed and patients end up with significant hypertension and they have to stop the medication. Many weight loss drugs have adverse benefits to risk profiles, as I said, with anxiety, hypertension, and so forth. And the weight loss may be modest. But more importantly than the weight loss is there's no scientific literature that shows that any of the medications that are available, whether it be the stimulant type of a medication that increase the metabolic pathways, those that limit the fat absorption, centrally acting serotonin, receptor blockers. None of these medications have been shown to improve either the long-term comorbidities or reduce mortality. So they may be nothing more than just a transient correction of what the patient reads on a scale, but does not change the long-term plan and the mortality. So one of the questions I want to ask is that though patients are in our office, and what do the patients ask for? And we may want to remember this answer. It's the glucagon-like peptide 1 receptor antagonist, the GLP-1RA. It's been a while since I've looked at a biochemistry book, so I have to go back and remind myself what the glucagon does. Glucagon is a chain of amino acids released from the alpha cells of the pancreas. It's triggered by hypoglycemia, and what it does is it affects multiple organs, and the release of the glucagon affects on the brain by increasing the satiety and decreasing the appetite. I'm mentioning that as the first because we'll come back to that shortly here. It increases this insulin secretion from the beta cells of the pancreas, thus dropping the blood sugar, serum sugar, and moves the sugar from the into the cells from the serum. From the GI tract, the cells absorbed into the cells, and at the level of the liver, increases the glucose production, increases the lipid breakdown, and increases the ketone body production. At the level of the adipose tissue, the brown tissue, the so-called the fat and the omentum, it increases the resting basal energy expenditure, and also increases the cardiac function by increasing the heart rate and the contractibility. So it essentially, if we're to sort of summarize all of these things, if I have a higher glucagon level, whether this is released by my alpha cells or given to me in a form of an oral pill or an injection, then I may experience some satiety, lower appetite, my blood sugar will go down, I'll have higher basal metabolic rate, and sort of burn more sugar and more fats, essentially. Looking specifically a little more in a form of a cellular level, if we look at the graph on the drawing on the left hand side, hypoglycemia is a triggering mechanism when the sugar moves into the cell. The way this hypoglycemia by glucose moving into the cell triggers a cascade at the level of the mitochondria, and ATPs release. The ATP opens a potassium channel, which causes a differential a potential gradient between the potassium and the calcium channel. Calcium rushes into the cell and releases the glucagon. So when I have sugar, when I have a higher glucose in the serum and that glucose gets moved into the cell, the initiation of the hypoglycemia and moving of the sugar molecule into the cell is what triggers the glucagon release. When you look at the normal physiology of the relationship between the plasma glucagon level and the sugar glucose release. As a patient consumes a sugar load, the glucagon is supposed to go down. As we want to think about it in a normal physiologic function, the insulin and the glucagon function in the opposite way, pointing to the opposite way. There's a paradoxical move in type 2 diabetic patients where as the glucose increases, even though it increases the insulin release in order to mobilize the sugar intracellularly, there's a paradoxical increase in the glucagon. And this may be one of the explanations why patients who are diabetic ordinarily gain weight with the treatment also. And this may be one of the reasons why GLP-1 class of medications work, and we'll get to it here shortly. Reviewing this again, looking at this, the GLP-1 that we talked about it, that this is actually released from the alpha cells of the pancreas. That's not all true. They're different. Part of it is also released from part of the GI tract and also from the brain. But we talked about is how in general it increases the insulin synthesis, increases the secretion of the insulin, and the end result is to decrease the blood sugar. From a GI tract perspective, it decreases the gastric emptying and slows the peristalsis. And this is probably one of the most common problems that the patients with GLP-1 class of medications complain. Primarily, they experience the nausea and the vomiting and the abdominal pain and the constipation, which we'll here talk about it shortly, is the cause of the most common compliance issue with all of the patients. At the heart level, we talked about that increases the basal sort of cardiac contractibility and the heart rate. And at the level of the brain, it's been shown to decrease the patient's perception of the hunger and increases the satiety. There's a lot of discussion about whether the GLP-1's mechanism of the primary mechanism of the action is a combination between the delayed in gastric emptying and delayed in the gastric peristalsis and the satiety issue, and that tends to be much more anecdotal rather than objectively identified. So there's studies to be made, and there's more science that needs to prove the exact mechanism by the GLP-1 for weight loss. Just looking at the class of GLP-1 medication, historically these were medications, glucagon-like peptide analogs that were created for treatment of diabetes. Early studies showed that patients experience the side effect at the time of the weight loss. There's a number of these medications out there. Some of them are not applied in the US by the FDA. Most common of them are weekly or daily injections, and there are also oral supplements, oral formulary that's available in one or two medications. When we're talking about the GLP-1 to the patient, I think it's important to sort of outline a few issues. One of them that this is a medication that needs to be taken. We don't want to use forever, but for foreseeable future. There is no clear pathway for why the weight loss is experienced. As I said earlier previously, that most expert in the field will point to the possible correlation between the motility, gastric emptying, and the perceived satiety and loss of appetite as the underlying reason, but it's not really clear if that's all there is to it. The issue that this medication has to be taken long term is critical to be explained to the patient that as of today, as of this presentation, there is no exit strategy with the GLP-1 medication, which means that patients may lose weight and they may keep it off for short term because there are no long-term studies, and also if and when they have to get off the medication for a number of reasons, we know that the weight will come back. Not only the weight comes back, but also the comorbidities that have resolved will come back. The earliest, the easiest way to sort of explain this to the patient may be the fact that if a diabetic, if a patient is taking the GLP-1 medication, if they're taking Wegovy or Ozempic for diabetes and they've lost some weight, we can all know what happens when they stop taking it. Their weight will come back, but now their diabetic is also poorly controlled. So it is very important to clarify with the patient why there is no sort of exit strategy with this medication. The contraindication for this medication is patients that may have a risk for thyroid nodules and medullary thyroid carcinomas or MEN2s. There's numerous studies that has been shown in the rodents that if they have the MTCs or MEN2 syndrome, GLP-1 causes significant growth of these tumors. The most common side effect of the medication has to do with the gastrointestinal. There is a study recently that was published from 2022 in Diabetic Journal that showed 44% of the patients taking Wegovy had significant nausea. Another study that was published in 2017 by a very large group that was both in US and Europe. They surveyed 10,000, near to 11,000 clinicians and patients, and over 1,000 of them were eventually included in the data analysis because one reason or another patients didn't follow up with the survey and all that. And as you can see is that from a patient's perspective, the number one reason why the patients would be taken off the GLP-1 medications were hypoglycemia, and very close to that was nausea and vomiting. From a patient's perspective, the number one cause why they stopped using the medication, and that was about 65% of the patients where they made them sick, they were nauseous, and 50%, close to 50% of them had significant vomiting with these medications too. So going back to one of the earlier slides that I talked about, the importance of correlating risk versus benefits, even if you take the effect of the value of the fact that these patients have to give these injections or take the tablets once a day or once a week for the foreseeable future at a significant cost, the risk and the side effect of the nausea, vomiting, low blood sugar causes a significant concern when it comes to sort of the relatively low marginal risk, low benefit compared to the risk of 50% of patients having nausea and vomiting, for example. So the GLP-1 plan, and I've referred to these previously. Again, these are Wegovy, Ozempic, Truda class of medications. They are glucagon-like peptide-1 receptor analogs. They mimic the function of the glucagon. They reduce the serum glucose, decrease appetite. The mechanism of action for weight loss is not completely clear. The weight loss is sustained as long as the patient takes medication. And it is important, as I said earlier, that to be aware, to share this with the patients, that there are no long-term outcome data available for these patients, which means that when the patient stops the medication, if and when at some point the weight will come back. There's a study in Diabetic Journal from 2022, just earlier last year, that was published and says 1 year after withdrawal of once a week subcutaneous semaglutide 2.4 milligram injection, which is sort of the highest dose of the medication. Patients are supposed to start at a low dose and incrementally, as tolerated, increase the dose. Participant gained 2/3 of the weight prior to weight loss. and with similar changes in the cardiometabolic variables. What this means is that the patients not only gain their weight back, but also their risk profile, things that would have improved, their blood sugars, their lipid panels, also return back to pre-treatment levels. I would like to talk briefly about the GLP-1 compounding. These are the promotions, emails, marketing that most of us may be getting in our office. GLP-1 class of medication, both Ozempic and Wagovy, became so financially lucrative for the pharmaceuticals that pharmacists would rather sell them off the prescription for weight loss rather than prescription for diabetes. So there's a shortage on that. Because of that, FDA sort of went down this road of possibly allowing some compounding to take place, and then the information is what it has become very murky and unclear for a number of reasons. Number one is that though compounding medications is a way to circumvent the patent protection. There's already legal challenges to a lot of these spas and compounding pharmacies that are producing these from the manufacturers. Also, in order to circumvent the patent protection, compounding pharmacies are using the peptide analogs in a salt base, and there's been significant incidents of complications of hypertension and hypertensive crisis that have been reported to the FDA, primarily because of the very high salt content of these medications. This pictures from a pharmaceutical compounding pharmaceutical that recommends these medications for sale to the physicians, and as you can see, their way is to have a salt mixture and a vitamin B12 into the mixture. We don't offer the injections in our office to our patients. We have no source for getting them, and the thing got clipped. It is recommended that any clinician who's contemplating using this medication contact their licensing and the regulatory agency to make sure that they can, from the proper channel, get these compounded medications. I'd like to shift here and go to the surgical component of the obesity. So briefly, we talked about the diet plans, we talked briefly about medication, and I think from a medical treatment options that we need to be aware of right now is the GLP-1, is the Ozempic and the Wagovy medications, and we need to remember and remind the patients that these medications have sort of as benign as nausea and vomiting may be, have a very high incidence of side effect and complications. For most patients, they need to be started on a low dose, and over a matter of months up to a higher dose. The weight loss is very varied, and their statistics have talked about 10-15 pounds for most patients, nothing more. And most importantly is that if and when the patients stop the medication, the weight will come back. Shifting now to surgical history, the treatment of obesity surgically has evolved over the last 30 years or so. We started from the old GI bypass, very effective, but very high complication of liver failure and of death. The jejunal and the small bowel resection exclusion. These patients end up with blind loop syndrome. And then the loop gastric bypass, which sort of was relatively low invasive, but these patients also had significant bile reflux, gastritis, and weight regain. Then evolved into the vertical banded gastroplasty, or the Foley pouch with a ring, and there's a whole bunch of other procedures in between them, but we'll sort of take it for that. The newest, the latest thing that has been out there is the intragastric balloon. There's been a number of balloons that have been have come to the market. Single balloon saline, then 2 or up to 3 balloons. Balloons that are also filled with air, and there's also some with nitrogen. The issue with the saline balloon was that they're so heavy, the patient has this chronic feeling of the nausea and vomiting and a stretch of the stomach, so that was switched to having a nitrogen and or filling it up with air, where it fills up the volume without really the weight of it. There's also a balloon that are released into the European Union but not in the US. They require endoscopy, and only one of them is able to be swallowed, the ovalium loop. The therapy has been found only to have a temporary effect up to 3 years, despite repeated balloon placement. The weight loss experience does improve obesity-related comorbidities, but typically the weight is regained and the positive effect of the comorbidities are resolved. There's a number of studies out there that have proven that balloons do not do anything long term. Balloons are one of those procedures that are advocated as to being a very simple procedure. The patient may be advocated to think about it as it's nothing more than an endoscopy. So on a risk benefit ratio, it may be advocated or sold to the patient as a very low risk procedure. But when you look at the long-term effect of it, the patient needs to every 6 months go and have it removed and replaced. And at the end of the thousands of dollars every 6 months, there's no tangible benefit to this procedure. So as a part of my practice, we recommend against any gastric balloon placement. When you look at the adjustable gastric banding, I think we're all mostly now aware of how this also did not work long term. Adjustable gastric banding with a removal rate of 6% annually and the need for revision of more than 2/3 of them after removal. It does not have to, it doesn't appear to be a long-term solution to obesity. This is the references are, I should have mentioned this earlier, all of these quotations and data that's quoted all have references scientifically. I'll make this available to the society, and for those of you that are interested, you can reference find the referenced articles. Adjustable gastric banding is also associated with short, poor, and long-term weight loss outcome and a very high failure rate. We do not, as a part of our practice, recommend anyone to get the adjustable gastric banding down. There was a study about a few years ago from Europe, which essentially said, parallel to what that first statement said, about 6% annually and 2/3 of the patient needed removed, that eventually over a 10-year period, nearly 100% of the adjustable gastric bandings need to be revised and or replaced. Which is why, as a matter of practice, if any patients are seen in our office for adjustments, my recommendations are for the bands to come out, and it's easier to remove the band that's not slipped or complicated electively versus having to deal with it on a weekend at the middle of the night when the band has suddenly slipped and it's leading towards perforation, bleeding, and so forth. Similar to the previous data, again, these are 3 references that nearly 50% of the patients required band removal, contributing to reoperation rate of 60%. Go back here, stomach has pushed up and the band has slipped. So this band needs to come out emergently. In this case, the band moved in an axis where you can sit, and there are cases where you can see sometimes the donut of the band itself. That also means that the band has slipped in an anterior posterior fashion. And so when we look at this animation, you can see this is a band of a patient that has marginally slipped. It's sort of I moved the cursor, it moved the back to the beginning. I'll just leave that at that. You can sort of see how the band is not quite between 0 to 90 degree, but just a little below the 0-degree angle, so it may be also slipping. And the next one, you can see how it has completely slipped now. So these two patients both had slipped band. These are reconstructions from the 3D image reconstruction from a CT scans that were done, and you appreciate how these bands are slipped. These patients need to be seen urgently by a patient, by a surgeon. The take-home message would be that a patient with a history of adjustable gastric banding that shows up with sudden onset of nausea, abdominal pain, they may experience shoulder pain, back pain. These patients need to be emergently be seen by a surgeon, or it's an after hour be sent to an emergency room. Why weight loss surgery procedures? As we discussed earlier, cause of obesity are multifactorial. There may be genetic, hormonal, diet and exercise, family, infertility, food and activity level related. We have very little control over our internal thermostat. If we think about it, we have very little margin into up or down regulating our metabolic pathways. The reason why weight loss surgeries work is that diets and exercise do not work. We talked about the long-term outcome of most of the medical treatment. The GLP-1 glucagon-like peptide medication is sort of the wild card here that remains to be seen what their long-term outcome of them are going to be. In my opinion, I think they may not work long-term, because as with anything else, as we secondarily control the end product, we're also down regulating the regulatory mechanism. So if we add the thyroid medication by medication, we turn down the TSA. So we just don't know what happens to the regulators of the glucagon when we give the patients glucagon 1 medication. We will talk about here and show that how the long-term outcome of the weight loss surgical procedures are. There are the procedure on the left is the gastric bypass, which used to be the most common procedure out there, and it has fallen off favor because it not only doesn't have a sustained long-term outcome, it is technically harder to perform, and it also has a higher complication rate. Adjustable gastric banding used to be one of the most common procedures out there because of a very aggressive and robust marketing by the manufacturers, and we all must have patients who had adjustable gastric banding and they've not done well, and they've had it replaced. The procedure that's marked sleeve gastrectomy is one of the most common procedures done out there. It's important to appreciate that this is not sort of the latest procedure that's been identified. In our practice, we've been doing the duodenal switches for 25 years or so, and every single one of these patients had sleeve gastrectomy. There were a subset of patients that we used to do the sleeve gastrectomy, and we'll continue to do them as a first stage of the duodenal switch for not losing them. And just briefly, essentially what happens is that we mobilize the greater curvature of the stomach, so the stomach is grabbed. This is a robotic sleeve gastrectomy that's done. We take the gastroepiploic and the short gastric vessels from the stomach, disconnecting them. So as we mobilize the stomach from all of the connections all the way to the splenic hilum, we have a tube in the stomach to allow us to give the size of the stomach, and as we've taken all of the short gastrics, we get to branches between the spleen and the stomach. It is very important that the surgeon takes the entire fundus and the stomach down from the splenic hilum, otherwise these patients will come back with inadequate weight loss and or some weight gain. When the entire stomach is removed, and I've sort of, for the sake of time, I've deleted or I've shown some of the video here, as we mobilize the splenic flexure and we take the entire stomach out from the spleen. I will continue doing this. Then we start doing the sleeve gastrectomy component, and you can see there's a tube in the stomach right now that allows us to size the stomach. That's a high 30s to low 40s size bougie dilator. So if you want to think about it, size of a thumb, over time this thing will stretch a little, but it will never go back to its original size. So the key is to make sure we take enough of the stomach without really causing a narrowing across it. So we position the tube at the incisura where the stomach comes down and gets close to the pylorus, and the stapler fires. We the part that's to our to the image's right by my picture is the part of the stomach that's going to come out, and the stapler leaves 3 staples on each side and cuts in between them, and as the stapler releases, I can sort of, at the interest of time, move this a little forward. All right, so, and then as we continue to fire more cartridges, you can see that's the stomach that comes out, and this is the part of the stomach that's the stomach that will stay in, and this is the stomach that will come out. So that essentially translates into about 75-80% of the stomach. So before we also leave the before we remove the stomach specimen, and we fill up the abdominal cavity with sterile water, pump air into the stomach by anesthesia staff, and so to make sure there is no air bubbles, which means that there is no leak. So this is the 75-80% of the stomach that comes out. This comes through one of the ports, and that's the part of the stomach that's left behind. looking at the long-term success of all of the weight loss surgical procedures, duodenal switch provides the best outcome, followed by sleeve. Gastric banding does the worst, and so does balloon, and gastric bypass is in between them. When we're looking at the surgical outcomes, this is an example of how we sort of want to quantify both the short-term and the long-term outcomes. So gastric bypass may provide the best 3-year outcome, but 5 years out, gastric sleeve patients do really well. Drug therapy is the one that there's lack of data. These are the ones that I said earlier, that we don't know what's going to happen to GLP-1 type of medications out there. We not only have to think about the weight loss and comorbidities, but we also need to look at the life expectancy. There's a set of data that was published back in 2020 by Swedish obese subject study, the SOS study, that when they looked at their control of the patients versus all of the weight loss surgical procedures, this was this SOS study included gastric bypass and the adjustable gastric banding. What they looked at was the life expectancy of the patients, regardless of the about 5-10% weight gain of those that had early weight loss. Up to 20 years, they did much better than their control of the patients that did not have weight loss surgery. Further comparing the outcomes of the weight loss and diabetic and non-diabetic patients. This includes patients at a younger age. What was shown again, that the weight loss should be offered to patients earlier. Again, this was a secondary result from the SOS study from 2020, that younger population, BMI at 20 years, those who had weight loss surgery earlier reaped the benefit of the weight loss up to 10 years at this study. And more importantly, if you look at the top bar graph, when you're comparing the incidence of diabetes, those patients that were diabetic early on and had weight loss surgery, after weight loss surgery, their diabetic blood sugars were lower than what the control was before and without weight loss surgery. When we look at all of these opposing forces of the cost is represented by the size of the circle, the benefits versus the risk. Diets may have low risk, low benefit, low cost. Medications may have mid risk with all of the complications, very expensive but also low benefit. I think it's important for us to distinguish between devices and the surgery. Gastric balloons and the band are devices that are implanted. They're associated with very high cost, relatively high risk, and low benefits, which sort of also relatively to this surgery, comparatively speaking, according to the MBSA QIP data, including the SOS data and the NIH published data, the mortality from weight loss surgical procedure is 0.3%. I want to remind ourselves about that high risk complication of the gastric balloon and the band, and the 40% complication of the medication. So statistically speaking, the relative risk benefit is much more in favor of the surgery. As to where do we go from here, the long-term outcome of the procedures and treatment we offer our patients need to be discussed. We need to also be careful not to necessarily just talk about the absolute risk. We need to distinguish between absolute risk in relation to the benefit, which means that the relative risk and the benefit options for each procedure needs to be evaluated and included. The longevity of the outcome is important. There is studies that have looked at not only the weight loss, but also the resolution of the comorbidities, but also patient satisfaction. Quite frequently, the weight loss and the improvement of the comorbidities and the patient satisfaction are all attained at a relatively lower point of weight loss, whereas patients who are experiencing the side effect of the device or the medication are not at all satisfied with the procedure itself. One other thing that we also need to consider is the long-term cost consideration. Weight loss surgical procedures may be costly at the front end, but for the most part, barring any unforeseen complications that occurs relatively infrequently, they do not require any maintenance long term. That's unlike the medications, injections, balloons, and banding that require long-term treatment. And in our practice, we've seen groups of patients that have come back, as I said earlier, that have started going down the path of PLG1 injections, and now they can't afford them, and they're gaining weight, and they're looking for alternative plans. So in summary, we outlined that diets and exercise don't work. We just can't tell the patients to eat right and exercise, everything will be fine. We need to intervene early. This includes also very young adolescents around puberty, and make sure their growth plates are closed, and it's easier and healthier for the young children not to become diabetic lifelong by avoiding their treatment and delaying their treatment. We should discuss the long-term plan with the patient.